Okay, so we're gonna start our next session. So it's a hepatobiliary and pancreatic session. So I would like to introduce the first speaker, Dr. Teresa Macorel. I hope it's right. is currently a physician in the medical oncology department at Valid Hebron University Hospital in Barcelona, Spain. Dr. Macorella is also the head of the GI Cancer Program Unit since April 2017. She's working in the gastrointestinal tumor team. So her talk will be about the continuum of care of metastatic pancreatic cancer.
So thank you very much for the introduction. Also, I want to thank to the scientific committee for inviting to be here today. For me, it's a great pleasure. It's my first time in Egypt, so I'm really happy to be here. So I will talk about the continuum of care, which treatment options we have in pancreatic cancer patients. So unfortunately, still in 2022, you can see here that the number of new cases of pancreatic cancer is too close to the number of deaths for this disease. It's one of the tumors with less advances in the last decade, so there's still a lot of work to do. Here you can see that pancreatic cancer is more common in men than in women. The incidence of pancreatic cancer varies all around the world. Egypt is probably in the middle. The incidence is between 4 and 7 cases for 100,000 in males and is between 2 and 3 new cases per 100,000 in women. So which treatment options we have in advanced pancreatic cancer? We have two treatment options, gemcitabine and nab-paclitaxel, and also FOLFIRINOX. Both regimens demonstrated a superior overall survival, but also progression-free survival and response rate compared to the standard gemcitabine. However, the FOLFIRINOX trial demonstrated higher incidence of toxicity, mainly GI and hematological toxicity. So how we can choose the best treatment option for our patients? Well, we have some clinical factors. For example, we know that in the FOLFIRINOX trial, the French trial, included only patients younger than 75 years old and also included only patients with a good performance status. On the other hand, in the IMPACT trial that tests the efficacy of gemcitabine and nab-paclitaxel, they include patients without a limit of age, and also they include patients with ECOG 0, 1, or 2. So today we tend to use more FOLFIRINOX for those patients fit and young, and we can use gem and nab-paclitaxel for those patients with older age and also ECOG performance status 0, 1, or 2. But what happened in those patients with young age and fit enough to be treated with both regimens? Which is the best treatment option for each of our patients? Do we have any biomarker that help us to guide our treatment decisions? Well, we have the retrospective data that show how in the classical subtype of pancreatic cancer, the FOLFIRINOX work better than did in basal-like subtype. So if you have a patient with a classical subtype, you have to use FOLFIRINOX because it works better. If we see the data with gem nab-paclitaxel, there is no differences between the classical subtype and baseline subtype. And you can see here that GATA6 is strongly associated with classical subtypes. So it's not so difficult to test for this GATA expression, and then you can have this classical subtype. And if you have this patient, maybe it's better to treat with FOLFIRINOX. But of course, this is retrospective data, and these have to be validated in a prospective trial. And in fact, we have now the PAS-1 trial that is ongoing, and we will see if confirms the results. And do we have any other biomarker? Well, we have the DDR alteration. The Know Your Tumor program from the United States show us how to have a DDR alteration, a germline BRCA, for example, is not a prognostic factor. For example, in the left side of your screen, you can see that in the blue line is patient with DDR alteration, and in the red line is patient without DDR alterations. When they do not receive platinum-based chemotherapy, the outcome is the same. But once you have a patient with a DDR alteration and you treat those patients with platinum-based chemotherapy, the overall survival becomes better than those patients without DDR alteration. And the difference in overall survival is 1 year. So it's really an important difference in metastatic pancreatic cancer patients. So the message is when you have a patient with a DDR alteration, BRCA1, BRCA2, or PALB2 mutations, you have to treat those patients with platinum-based chemotherapy. And does the line matter in which we treat those patients with platinum-based chemotherapy? Well, again, retrospective data show us, unicentric activity experience show us how this benefit mainly is driven by the first line treatment more than second or third line. So that's important because that means that we have to find these patients with this BRCA alteration or PALB2 alteration as soon as possible in order to treat those patients with platinum-based chemotherapy in first line better than in later lines. And which is the best schedule with platinum-based chemotherapy for our patients? Well, we don't have the answer to this question. We have the experience of the Polo trial, in which 80% of the patients were treated with FOLFIRINOX. So FOLFIRINOX is a good treatment option for patients with these alterations. If not, the Illinois Relief published this data of this randomized phase 2 trial that include patients with germline BRCA1, BRCA2, or PALB2 mutations. And those patients were randomized to be treated with gemcitabine, cisplatin, and beliparib, a PARP inhibitor, or gemcitabine and cisplatin. This is a negative trial. However, you can see this spectacular forest plot in a metastatic pancreatic cancer patients with a response rate near 65%. So gemcitabine and cisplatin is a good treatment option for this subset of patients with pancreatic cancer and BRCA1, BRCA2, or PALB2 mutation, especially in those patients that are not fit enough to be treated with FOLFIRINOX. And what about PARP inhibitors in pancreatic cancer patients? The Polo trial, it was a randomized international phase 3 trial that included patients with germline BRCA1 and BRCA2 mutations that after an induction period of treatment with platinum-based chemotherapy, a minimum of 16 weeks of chemotherapy and no progression, patients were randomized to be treated with olaparib or placebo. And the primary endpoint of this trial was PFS, and this is a positive trial with a hazard ratio of 0.553 and a median progression-free survival of 7.4 months in the olaparib arm and 3.8 months in the placebo arm. Also, the Polo trial demonstrated a superior response rate in patients treated with olaparib with a response rate of 23% compared with placebo arm. And interestingly, and I think this is the most beautiful data that we have from the Polo trial, is the duration of response. Patients that receive olaparib and response presented a longer duration of response than patients treated with placebo. And this median duration of response, it was more than 2 years, 24 months. And you have to take into consideration that these are patients with metastatic pancreatic cancer. So that's an important point. However, we do not have differences in overall survival between both groups. Why? We don't exactly know. Probably one is because Polo trial, it was not powered to see differences in median overall survival. Also because some patients treated with placebo receive olaparib at progression. And also because majority of patients receive platinum-based chemotherapy in both arms at progression. And for the reason, we have a high overall response in median overall survival in both arms, 19 months, but no differences in overall survival. So with these results, olaparib is a new standard treatment and was approved by FDA and also by EMA for patients or as a maintenance treatment for patients with germline BRCA1 or BRCA2 mutations who have metastatic pancreatic cancer and have not progressed after a minimum of 16 weeks of platinum-based chemotherapy. Of course, for this, we have to do the effort to test all our metastatic pancreatic cancer patients before or during the first line in order to identify those patients. I have to remember you that only 50% of patients with pancreatic cancer are germline BRCA mutated tumors presented family history of cancer. So for this reason, we have to test ideally all our patients. And we have other PARP inhibitors that demonstrated activity in pancreatic cancer. This is data from a single-arm phase 2 trial, rucaparib, demonstrated in a same or similar strategy than olaparib. After induction chemotherapy and with no progression, patients were treated with rucaparib. And you can see here how the response rate is also high, 41%. And we have this promising PFS activity of 13 months. And here, interestingly, they include not only patients with germline BRCA1 or BRCA2 mutations. They include also patients with somatic BRCA mutations and also with germline PALB2 mutation. And they demonstrated activity in all these different subtypes, in germline BRCA1 or BRCA2, in germline PALB2, and also in somatic BRCA mutations. And what about second-line treatment in pancreatic cancer? Which options do you have? Well, we have this Napoli 1 trial. It is the only randomized phase 3 trial that we have. Include patients at progression of gemcitabine-based chemotherapy and randomize the patients to be treated with Naliri, that is a liposomal formulation of irinotecan, 5-FU as a control arm, or Naliri and 5-FU as another experimental arm. The primary endpoint of the trial, it was overall survival, and this was a positive trial, demonstrated the superiority in overall survival in those patients treated with Naliri 5-FU compared with 5-FU. And consistently, the trial also demonstrated superiority in all the other efficacy endpoints, progression-free survival, and as you can see here in the slide, with a hazard ratio of 0.5, but also in the response rate and in the decrease in tumor marker. So after the Napoli trial, Naliri and 5-FU is a new standard treatment that we can use for those patients that progress to gemcitabine-based chemotherapy. Do we have any other treatment option for this population? Well, we have conflicting results with oxaliplatin-based chemotherapy. As you can see here, the CONCORD trial demonstrated the superiority of the OFF compared with 5-FU. However, the Pancreatic trial, that is a Canadian trial, demonstrated a detrimental effect of FOLFOX compared with 5-FU. So if we do not have a patient with a DDR alteration, it is not clear to use oxaliplatin-based chemotherapy after gemcitabine-based chemotherapy. And what happened in those patients that are treated in first line with FOLFIRINOX? We do not have randomized data that demonstrated the activity of gemcitabine and nab-paclitaxel after FOLFIRINOX-based chemotherapy, but we have some retrospective data that show us that this combination can be active in this situation. Also, in the last ESMO meeting, the French group presented the PRODIGE 65 trial that is a randomized phase 3 trial that includes patients after progression to gemcitabine-based chemotherapy, and those patients were treated with gemcitabine alone or with gemcitabine and paclitaxel, not nab-paclitaxel, paclitaxel. And this is a negative trial. The overall survival is similar between both groups. It is true that maybe the patients treated with gemcitabine and paclitaxel presented a better PFS and better response rate, but the trial is negative. However, we would like to see this data of this trial with a combination of gemcitabine and nab-paclitaxel that demonstrated activity in this tumor. Also, I want to highlight that 32% of patients and 47% in the control arm were treated in third-line setting. That means that this is a high unmet need because we do not have treatment option for these patients that are fit enough to be treated with a third-line treatment option. And what about patients with pancreatic cancer and MSI tumors? There's any role for immunotherapy? Well, the Keynote 158 trial that include different solid tumors with MSI high tumors include some patients with pancreatic cancer MSI tumors and demonstrated modest activity, not so good activity, but modest, treated those patients with pembrolizumab. So with this, I think it's very difficult to find a patient with pancreatic cancer tumor and MSI tumor. It's less than 1% of our patients, but once we have a patient with these characteristics, we have to do the effort, I think, and this patient deserves to be treated with pembrolizumab. However, the rest of the patients with pancreatic cancer without MSI tumors don't have to be treated with immunotherapy. We have this, for example, different trials, but for example, we have the Canadian trial. This is a randomized phase 2 trial in first-line setting that randomized the patients with pancreatic cancer to be treated with GemNab or GemNab, paclitaxel, durva, and tremelimumab. And this is a completely negative trial. So for now, this population don't have to be treated with immunotherapy. What about to use NGS analysis to guide our treatment decision? Do we have to spend our money doing an NGS analysis in our patients? Well, Know Your Tumor program reported that 20-25% of pancreatic cancer patients presented targetable alterations, and also that when you treat these patients with matched therapy, they live longer than those patients without target alterations or with target alteration but not treated with matched therapy. And in fact, this is an important, especially in those patients with KRAS wild-type tumors. We know that only 5% of patients with pancreatic cancer presented a KRAS wild-type tumor, but in this subgroup of patients, the targetable alterations are more common. And this is especially frequent in those patients younger than 50 years old. Our group find that patients younger than 50 years old with advanced pancreatic cancer presented 20% KRAS wild-type tumors. And within this KRAS wild-type tumor, we have higher incidence of targetable alterations. So if you have a patient, a young patient with pancreatic cancer, you can test KRAS. If the patient presented a KRAS wild-type tumor, you can do the effort to do a complete NGS analysis. Why? Because we have some, for example, fusions that can be treated with a target therapy. For example, in the Libretto-1 trial that was recently published, they demonstrated in different solid tumors with RET fusions that inhibit RET. For example, with selpercatinib can have a really promising activity. And in this case, they include 12 patients with pancreatic cancer and with a RET fusions, and they demonstrated a response rate of 50%. And the duration of response was not reached in that trial. So this is a good option for this small group of patients with RET fusions. And also another example is the senocutumab. We know that senocutumab presented this promising activity with a response rate of 42% in patients with pancreatic cancer and NRG1 fusions, that it is especially frequent in those patients with KRAS wild-type tumors and young patients, younger than 50 years old. And can we target the untargetable alteration, that is mutations in KRAS? Well, we have this data that it was presented in the GIS committee this year with adagrasib, that is an KRAS G12C inhibitor, in patients with pancreatic cancer, refractory situation, and with KRAS G12C mutation. And as you can see here, the response rate is 50%, that is really impressive in this population. So again, test for KRAS, and if a patient presented this mutation, it is interesting to treat with this strategy. Near future, what are we doing in order to improve these treatment options? Well, when one of the interesting strategies is try to do this tumor more sensitive to immunotherapy, for example, with the LEAF strategy. LEAF is overexpressed in patients with KRAS mutated tumors. So in pancreatic cancer patients, it's really overexpressed. And we know that LEAF is evolved in the immunosuppressive microenvironment of pancreatic cancer. We have some preclinical data that show us that if you block LEAF, you can have a more immune infiltrating pancreatic cancer tumors. And with this rationale, we have now an ongoing phase 2 clinical trial that treat patients in first-line pancreatic cancer with LEAF inhibitors plus durvalumab plus gemcitabine and nab-paclitaxel. We will see if with this strategy we have better results with immunotherapy in pancreatic cancer. And if not, we have another strategy, that is to use an oncolytic adenovirus in order to increase the immune infiltrate in pancreatic cancer, again with the same strategy, to do that chemotherapy and immunotherapy works better. Today we have a phase 2 clinical trial that is a randomized trial with gem-nab-paclitaxel plus this oncolytic adenovirus in order to increase the activity of this chemotherapy. And also I think what it is important is to do these clever designs, for example, this Morpheus trial in which we test different immunotherapy strategies, but also only in a small cohort of patients in which if the strategy is working, we increase the number of patients treated with this strategy. And if the strategy is not working, we close the cohort. With this, we put less patients in risk and we can try different strategies. So to sum up, FOLFIRINOX and nab-paclitaxel are two standard first-line treatment options in metastatic pancreatic cancer. Of course, it's crucial to develop more treatment strategies for this disease. And the proportion of patients that presented a metastatic pancreatic cancer and that are candidates to second or to third-line treatments is increasing, and we do not have enough treatment for these patients. We have only one treatment option in second line, Nalirium 5FU, that is approved after gemcitabine-based chemotherapy, and olaparib is approved, is a new standard treatment as a maintenance treatment for those patients with germline BRCA1 or BRCA2 mutations after platinum-based induction chemotherapy. Finally, we have disappointing results with immunotherapy in pancreatic cancer, and of course, we need with new strategies that are ongoing to improve the results. And with this, thank you for your attention.
Thank you, Professor Teresa, for this excellent presentation, and we will have the question at the end. So we'll not keep we'll keep things flowing. So I'd like to introduce Professor Arnold Vogel from Germany. He's going to give us a talk about the practical approach in the management of metastatic and unresectable HCC in 2022. So Professor Vogel.
So I just said thank you very much for inviting me, and it's really a great pleasure to be part of your conference and give you an update on the treatment of advanced hepatocellular carcinoma. And I'm also looking forward to our discussion later on. As you might understand, I usually like to start off with the ESMO guideline. And I think we have to update it again. I mean, we did it last year, but at the moment, so many things are happening in HCC that we really have to write an update every year, which is exciting and which tells us that really we have a lot of positive phase 3 studies. And with this, specifically in the field of advanced HCC, we have more and more options. And now treatment of these patients is getting more challenging because, I mean, in the past, we just had one option. Now we have a lot of options, and we really need to decide what is our best treatment for our patient. And as you know, we do not really have good biomarkers to guide treatment decisions in the advanced setting. I do not want to spend too much time in earlier stages, in intermediate stage. As you know, this is still dominated by local therapies. Nevertheless, in BCLCB, we need to be more cautious with the intra-arterial therapies, TACE and Y90. I think we really need to carefully select our patients for local treatment. And if they are not really good candidates in which a supra-selected treatment is possible, we definitely should try to start systemic therapies as early as possible, because as you know, most patients have a very advanced liver disease, poor liver function, and with every treatment, we might lose liver tissue, which makes it really difficult any further treatment. So early treatment is important, and we have options, and we have made progress in recent years. When you look at the median overall survival in the first-line setting, you can see a couple of trends here. I mean, first, in the beginning, when we only had sorafenib available, and sorafenib was the control arm in most of these trials, we had a median overall survival of around 1 year, and we did not really make any progress. This has now changed if you look to the right-hand side, and not only in the experimental arm, but also in the control arm, we are seeing a longer survival, which I think is most likely mainly, not only, but mainly related to the opportunities we have for sequential therapy. And having these options for second and even third line treatment in HCC, we can now achieve a median overall survival of around 14 to 15 months with sorafenib. But when you look at the latest studies, we do have a cut at around 14, 15 months, and we do not really observe longer survival. Very interesting, the LEAP-002 study in which lenvatinib was a control arm, we achieved a median overall survival of 19 months, as you know, for lenvatinib. So it looks like that also for lenvatinib, we do see a longer survival compared to the pivotal phase 3 study, and which seems to be longer compared to what we are observing with sorafenib, if you want to do such a cross-trial comparison. And the other observation we can make is that with the IO-based combinations, we are now having a lot of trials where we achieve a median overall survival of 20 months. At the moment, we are not really making a lot of progress, that we are getting a much longer survival, but 20 months is now feasible with these IO-based combinations in the first-line setting, and I will show you some more details in which direction we are heading. So the monotherapy with nivolumab or pembrolizumab was in the phase 3 studies was not really successful, so we did not get an approval by EMA, by FDA. We have some approvals. And since we do not have a biomarker, it was important that we got effective combinations. And one very effective combination is the combination of an VEGF antibody with a checkpoint inhibitor. And this was shown in the IMREF 150 study, but also in the Orient 32 study. And we do really see a clinically meaningful, longer median overall survival for the IO-based combination compared to sorafenib. And I think when you consider the median overall survival we are observing with monocheckpoint inhibitors or with bevacizumab alone, we can postulate that we have here a synergistic efficacy. So the combination of both leads to longer survival as we would expect from either drug alone, or if we just would give them sequentially. So most likely we have here synergistic activity. This is what I mentioned already before. The Checkmate 459 study is negative, but now we have seen 2 positive studies in the first-line setting, but this was a little bit cheating because here we are not looking for superiority, longer survival, but non-inferiority. And 2 drugs were able to have positive phase 3 study with a non-inferiority, durvalumab in the Himalaya study, and very recently, tislelizumab in the Rational 301 study published at ESMO a couple of weeks ago. And when you look at the median overall survival, you can see it is very consistent. Yeah, we have a median overall survival of 16 months, which I think is not bad. And which usually comes along with not too many side effects and a very good quality of life for our patients. So I think if we get an approval by EMA, it could be an option, but we need, of course, to decide who would the patient that would benefit from such a treatment. So the next combinations that were evaluated and where many of us thought that they would be effective are basically the checkpoint inhibitors with tyrosine kinase inhibitors, which have shown efficacy in the treatment of HCC. And the first disappointment was certainly the COSMIC 312 study, in which the addition of atezolizumab to cabozantinib in the first-line setting did not lead to a longer median overall survival compared to sorafenib alone. Even though we have to acknowledge that the median overall survival of sorafenib was 15 months, I think one of the longest median overall survival we have observed so far in a phase 3 study. Nevertheless, the curves are not separating. So there was no benefit and the company will not proceed with this combination. But this was the first indication that, contrary to what we were expecting, the combination of an TKI and the checkpoint inhibitor is not only not synergistic, but maybe that we are even not seeing additive activity. Then we had 2 studies presented at ESMO. One is the SHR 1210 study, mainly a study that has mainly recruited in Asia, a lot of Chinese patients with camaralizumab and the rivaroxabanib, apatinib. And this was clearly a positive study. I mean, we have a really significant survival benefit compared to sorafenib. Sorafenib performed well in this study, as you can see, median overall survival of 15 months, and that was improved almost by 7 months with this IO-based combination. So clearly a positive study. It is a new drug for many of us in the West. If we get an approval, and there's a question mark because only 17% of the patients were recruited outside of Asia. But if there's an approval, I think we really need to learn to work with this combination. But we have to wait and see what EMA and FDA will, how they will consider this combination and whether they will grant approval for this combination. Another study that was presented at ESMO was the LEAP-002 study, pembrolizumab and lenvatinib. I think many of us, including myself, thought that this is a very active combination and that the trial really had a good chance to be positive. It is an active combination, as you can see in the median overall survival of 21 months for the IO-based combination. However, what many of us did not expect that the control arm performed so well. Median overall survival, as I've shown you before, of 19 months. And if you compare this with the data from the REFLECT study, I think this is almost 6 months longer median overall survival for lenvatinib. We knew before that lenvatinib is an active drug. All secondary endpoints in the REFLECT study were clearly improved compared to sorafenib. And many of us did not really understand why there was no benefit in median overall survival. Yeah? We still cannot explain it. I think the longer survival we are observing today here in the LEAP-002 study is certainly also related to maybe some baseline characteristics which were different in the REFLECT study and here in the LEAP study, but it was not so many points that were really different. And what was clearly a difference is that we have more effective second-line treatment of almost 50% in the LEAP-002 study, which certainly has contributed to the long survival. And with that, the study was unfortunately negative. Lenva pembro, median overall survival 21 months, effective combination. However, there was no significant benefit compared to lenvatinib alone. And again, here, as what I have said before, for cabozantinib and atezolizumab, I think what we have observed with atezo-bev, this synergistic activity, is something we are not observing here. At best, when you look at the curves, we have some additive efficacy. Yeah? So what the difference we are observing here might be the difference we would observe with pembro alone when you look at the survival curve. So here, most likely no synergistic activity. And I think we really need to better understand why certain combinations really work, are synergistic, and others are not. Nevertheless, we have now more options. I have shown you a couple of positives tried, and now we really need to decide how should we treat our patients. And there are a couple of points we need to consider. Can we treat with IOs? Yeah, do we have contraindications, underlying autoimmune diseases, liver transplantations? Should we look at the underlying liver etiology, efficacy data, liver function? So there are a couple of points we can consider. And I just want to show you here in this cross-trial comparison, which we should not do, that we really need to think about the endpoints we have available today. Yeah, of course, we say median overall survival is most meaningful for our patients. I agree. However, when you look at the difference in median overall survival, even I acknowledge that this cross-trial comparison is difficult. You can see there are now really striking differences. Yeah, so median overall survival alone is not a sufficient endpoint to decide we take this or that combination. Yeah, so we have to incorporate more either endpoints or safety profile in our decision making. Yeah, and other endpoints you might want to consider are, for example, the progression-free survival. Yeah, and here, interestingly, the longest progression-free survival we have so far observed was actually with lenvatinib. Already in the REFLECT study, we have observed a long median overall survival of 7.4 months, and now it was even 8.1 months. And this was even a little bit longer compared to atezolizumab and bevacizumab. Another endpoint you might consider as important for decision-making might be both the overall response rate or the disease control rate. And as you know, with sorafenib, response rate was very low, and also the disease control rate was only around 50%. Yeah, and this has clearly changed. We do not have now, as you can see on the left-hand side, on the lower part, we have a lot of combinations with really nice response rate by RECIST 1.1, which are between 20 and 30%, which is certainly exciting. And also the disease control rate is now getting close to 80%. So we do have a lot of really active combinations, and again, the differences are moderate. And here, in terms of efficacy endpoints, it might be difficult to decide what is your preferred treatment. Another point, as I mentioned before, is certainly the side effect profile and the effect of the quality of life. But this is where we stand today in 2022. We have positive data for at least 6 or 7, if you like, drugs or combinations. Yeah, so we need to decide: do we start with a TKI monotherapy or IO-based combinations? Yeah, if we go for TKI mono, we have sorafenib and lenvatinib, and I think with the LEAP-002 data, very good efficacy data for lenvatinib. And then on the other hand, we have the checkpoint inhibitors, either as monotherapy. I think we really need to decide who could be a candidate for monotherapy, probably not too many patients. And then we have very interesting combinations, yeah, with a TKI, yeah, rivaroxaban, dual checkpoint inhibition with durvalumab, and with an VEGF receptor antibody bevacizumab. Yeah, so interesting combinations, different side effect profiles, kind of similar efficacy endpoint, even though we have to acknowledge cross-trial comparison is difficult, as said before. Once we have decided on the first-line treatment, the patients will eventually progress, and we need to decide on second-line treatment. Here, even getting more difficult because, of course, we do have drugs with phase 3 evidence, but this evidence has been generated in patients after sorafenib treatment. So we do not have any phase 3 evidence for any of these drugs or combinations after the new first-line treatment. Nevertheless, I think we all agree, and all national and international guidelines strongly recommend a sequential treatment. And why? What we have observed before is that we are getting a median overall survival of around 2 years for patients that are fit enough for sequential therapy. These are both the post-hoc analyses from first-line trials, as you can see here, for the REFLECT study, but also from post-hoc analyses from second-line trials, as shown here for the research and celestial study. And I think these data are really convincing and supporting that we treat our patients with different combinations. When we look at the patients that are treated in the second-line setting in clinical trials, I think we have, these are all Child-Pugh patients, of course. Yeah. When we look at the baseline characteristics, we do not really see significant differences between the 3 trials that have been published. I think we have here our most important prognostic markers: ECOG performance status, tumor stage, vascular infiltration, and also liver function, and AFP value. And you can see they are all pretty much well balanced, and we have more patients with an IB2 compared to an IB1 in the second-line setting, but the other way around when you look at patients in the first-line setting. When we look at the efficacy data, I think this has been published many years ago, and you are all very much aware of these 3 well-done studies. And when we look at the efficacy data, you can see they are also very similar. So very similar situation I have shown you before for the first-line trials. Yeah, so the median overall survival is between 10 and 11 months, and the progression-free survival is somewhere between 3 and 5 points. So based on the efficacy data, it's difficult to suggest that either of these drugs would be most efficient. Yeah, and what we can do then is we can do we would like to see head-to-head comparison. One head-to-head comparison I have shown you before. This is, however, a comparison in the first-line setting. Nevertheless, both drugs might today be used in the second-line setting. And if then we have now in the second-line setting the same situation. What is the more active drug, lenvatinib or sorafenib? Again, we have to clearly acknowledge both have been tested only in the first-line setting. But personally, I think lenvatinib is here the more active drug, and I would be my preferred suggestion in the second-line setting. And the same here for the comparison cabozantinib sorafenib. Again, we have to acknowledge that this is the first-line comparison, but both drugs would most likely be used mainly in the second-line setting. And for cabozantinib from the celestial study, we have second-line data. And when we do here this head-to-head comparison for cabozantinib and sorafenib, we could argue that cabozantinib is also the more active drug compared to sorafenib, but this is just an interim analysis which did not yet reach the level or the threshold of significance. So we have to wait for further follow-up from this study. One point I would like to also mention is that we have good data for checkpoint inhibitors in the second-line setting. Yeah, so the Keynote 224 study has been nicely reproduced in 2 phase 3 studies, Keynote 240 and Keynote 394. And I think the picture here is very consistent. We have very consistent median overall survival of around 13 to 14 months with pembrolizumab in the second-line setting, which is longer compared to everything we have observed with the TKIs I have shown you before. Of course, the majority of patients will be treated with checkpoint inhibitors in the first-line setting. However, some patients might get in TKI in the first-line setting because they were not deemed to be suitable for checkpoint inhibitors in the first-line setting. And here, I think when we are running out of options at some point, a checkpoint inhibitor like pembrolizumab could also be an interesting option as second-line treatment. So what can we do today? We have different starting options. We start with an IO-based combination, atezobev durva-tremi, maybe one of the new combinations. We can then do a TKI sequence. So we use either of the phase 3 studies with phase 3 evidence. Yeah, could be lenvatinib, sorafenib, but maybe also cabozantinib or regorafenib. Yeah, off-label use, of course, no evidence. Or we can consider continuation of the immune checkpoint inhibitors. And I will show you 2 studies in a minute which evaluate exactly this question. On the other hand, when we start with lenvatinib or sorafenib, we would most likely do the TKI sequence I have shown you before. But in some cases, and I apologize for the German here, we can also think about switching to a checkpoint inhibitor in the second-line setting. And you know, we have the approval by FDA for nivo-ipi, and I have shown you the data for pembrolizumab. These are the Keynote 240 is a negative study, as you know. The 394 study is a positive study, but we have good data for pembrolizumab in the second-line setting. And if you have started with lenva or sora in the first-line setting, I think this is an interesting option. So we now need to better understand what are the options in the second-line setting when we start with an IO-based combination. And one study we are performing at the moment in Germany is a multi-center IO study looking at the efficacy of lenvatinib and pembrolizumab after failure of atezolizumab and bevacizumab. And I think this is a very interesting combination, and it's a very effective combination, even though the trial was negative. And I'm really looking forward to understand whether this combination has also activity after failure of atezolizumab and bevacizumab. The same context is also evaluated in a phase 3 study. Atezolizumab here as a checkpoint inhibitor with either lenvatinib or sorafenib compared to lenvatinib or sorafenib alone after failure of atezolizumab and bevacizumab. It's a global phase 3 studies, and we really need to recruit our patients to get good data. Yeah, even if the study is negative, I think we will have data for lenva and sora in the second-line setting, which could be really helpful for decision making. With this, I would like to end. So my take-home message for this systemic therapies would be: so we have now positive trials for monotherapy. It has activity in a subgroup of patients. At this point in time, we do not know who are these patients that are responding. We need a biomarker. I've shown you the combination of VEGF-directed therapies with checkpoint inhibitors. They appear to be synergistic, yeah, clinically meaningful survival benefit in the ORIENT and in the IMREF study. TKIs and ICE are not as effective as we thought. They are maybe not even additive in terms of efficacy, with the exception of rivaroxabanib and pembrolizumab, the Asian combination. Yeah, and nevertheless, checkpoint inhibitors, dual checkpoint inhibitors are also effective. Durva-tremi, I did not go too much into the details, but I think durva-tremi, Himalaya study, largest study in the first-line setting, clearly improvement in overall survival compared to sorafenib, positive study. We have the monotherapies, durva-atezolizumab, I have shown you before. And of course, patients that are not candidates for checkpoint inhibitors, we have a good option, a good old option, lenvatinib, with a new survival data of 19 months, also very interesting. We strongly recommend sequential therapies. It's an evidence-based free area. I strongly recommend to include patients into the running clinical trials or use any of these drugs with phase 3 evidence. And with this, I would like to end, and thank you very much for your attention.
Okay, thank you, Professor Vogel, for this excellent presentation. Professor Vogel will be staying with us, or I can ask him questions now. So I will start with a question from my side. So I'm actually interested in your comments about the major discrepancy of the results of the control arms in the HCC studies. We find like a peculiar pattern of response with theoretically a similar group of patients. So with sorafenib, with lenvatinib, so in their original studies, they give a control arm of 7 months and this range. And then in certain studies with a combo of pembro plus lenvatinib, which has actually reached 21 months, and still it was negative because Lenvima was super at this study. So is this because of the heterogeneity of the HCC, because we don't have tissue, so we are actually missing something in the disease, or it's just a play of chance? What's your comment?
Yeah, I think it's a good question, and I personally, I do not believe in chance. I think biomarkers would definitely be extremely helpful. And I agree with you that HCC is also a heterogeneous disease, but I think the longer survival we are observing at this point in time is mainly related, not only, but mainly related to the subsequent therapies. Yeah. So when we look at the baseline characteristic, and I did not show you the data, but I really did a direct comparison between REFLECT and LEAP 002. And when you look at the baseline characteristics, they are not so different. Yeah. So just from baseline characteristics, there are no significant differences. There's today less prior treatment with local therapies, and there's certainly more treatment of effective second-line treatment. Yeah. So I think heterogeneity is an interesting point. At this point, it is, however, a little bit evidence-based free to say which subgroup would respond more or less to lenvatinib. We don't really know that. And for me, from a clinical point of view, I think it's more related to the subsequent treatment we can do today.
My second question is, in case you started in first line with atezo-bev, what factors you depend upon in choosing the second line? Is the disease-free affect your decision? Progression-free affect your decision? Side effects affect your decision? What the parameters you depend upon?
Yeah, that's also a very interesting point. So when you look at the post hoc analyses of the phase 2 studies, it appears that when patients are responding very well to sorafenib, they're also responding better to the TKI in the second line setting. So I'm not really sure whether it's a sign of TKI sensitivity, but there's always a trend when you have in the Celestial study, it has been nicely shown, when you have a longer survival with sorafenib in the first line setting, you are getting also a longer survival with cabozantinib, and the hazard ratio is, if at all, I mean, it's more improving. I think we do not see this kind of pattern when we start with a checkpoint inhibitor. So I think if you have a response to a checkpoint or to atezo-bev, it does not really predict whether you have a response to a TKI in the second line setting. Yeah, so survival can be different, can be affected by the checkpoint inhibitor in the first line setting, but I think it does not really have an effect on my decision making. Yeah, and if I could just decide based on efficacy, I think we have with lenvatinib and cabozantinib two really active drugs. I mean, one has only been tested in the first line setting, the other in the first and second line setting. And this would be my preferred choices in the second line setting. I think the combination with IOs is also very interesting, but this is something I cannot do outside of clinical trials here in Germany. So I would definitely try to include our patients in either our own study or the IMRAPE 251 study to really learn more about this IO beyond progression concept.
Okay, so thank you for your time. I really have a lot of questions, but because of the time, we have to proceed forward. This was an excellent presentation. Thank you, Professor Vogel.
Thank you very much.
Okay, so
thank you for inviting me.
Yeah, same. So I guess Professor Teresa. So it's time for your next talks. And its title would be "What's New in Biliary Tract Cancer."
So thank you. So now we change the topic to biliary tract cancer. I think it's an exciting tumor and very interesting tumor, and we have new treatment options in the last decade. So we will try to review in this presentation. So first of all, we have to understand that biliary tract cancer is an heterogeneous disease that includes gallbladder, ampullary cancers, intrahepatic cholangiocarcinoma, periliary cholangiocarcinoma, and extrahepatic cholangiocarcinoma. And these different tumors presented different etiology, different symptoms at diagnosis, and importantly, different molecular profiles. So let's start with chemotherapy. Which are the treatment options that we have in biliary tract cancer, and which are the new strategies that we are working on? So regarding the adjuvant setting, the BILCAP trial, in a pre-planned sensitivity analysis that adjusts the results for prognostic factors, they demonstrated that 6 months of capecitabine, it was superior in overall survival than the observation after the surgery of biliary tract cancer. So this trial established the standard that we use, I think, all around the world to treat our patients with the adjuvant strategy, 6 months of capecitabine. However, we are, all of us are waiting the results of the ATICA trial. That is a phase 3 clinical trial that randomized the patients after the surgery to be treated with capecitabine or cisplatin and gemcitabine. Now, moving to the metastatic disease, the ABC02 trial demonstrated that gemcitabine and cisplatin presented a superior overall survival than gemcitabine alone, with a median overall survival of 11 to 7 months compared with 8.1 months. And this trial established the new standard first-line treatment option for biliary tract cancer, I think, all around the world. And we have some intention to improve the results of the cisplatin and gemcitabine. For example, this phase 2 trial that did the ASUICOC group, in which they combined cisplatin, gemcitabine, and also nab-paclitaxel. This triplet combination demonstrated in this single-arm phase 2 trial a promising activity with a response rate of 45% and a PFS of 11 months, and this is in first-line setting, however, with higher toxicity profile. That means if one day they demonstrated that this is better than gemcitabine and cisplatin, this will be a treatment option for a selected group of patients that can be treated with this toxicity profile. Nowadays, we have a phase 3 clinical trial that the recruitment is completed from the ASUICOC group that randomized the patients in first-line setting biliary tract cancer to be treated with cis-gem and nab-paclitaxel or cis-gem. So we will see the results of this trial and if this change the standard of care in this subgroup of patients that can be treated with this strategy. What about second-line treatment options? The ABC06 trial demonstrated modest activity of FOLFOX compared with best supportive care. So this is an option for our patients. And also the Korean trial, the NIFTY trial, demonstrated that the combination of Naliri and 5-FU, it was superior to 5-FU. So in this subset of patients, it seems that there's another treatment option after gemcitabine and cisplatin, that is the Naliri and 5-FU. However, in the last ESMO meeting, Dr. Vogel presented data of this combination, Naliri and 5-FU, compared with 5-FU, in population outside of Asia, so Western countries, that and this trial, the randomized phase 2 trial, failed to demonstrate the superiority of Naliri 5-FU compared with 5-FU. So it's a different result than the Korean population. They reported a higher toxicity profile in the combination arm, in the Naliri 5-FU arm, and maybe this can influence the negative results of this trial. Well, now let's move to immunotherapy and let's review the data that we have in order to see if we have a new standard treatment option in first-line setting in biliary tract cancer. The TOPAZ trial is a randomized phase 3 trial, international, that includes patients in first-line setting biliary tract cancer. Patients were randomized 1-to-1 to be treated with durvalumab, cisplatin, and gemcitabine, or placebo, gemcitabine, and cisplatin. And interestingly, patients were treated only with 6 months of chemotherapy, and after these 6 months of chemotherapy, they continued with durvalumab until progression or placebo until progression. The primary endpoint of this trial was overall survival. And you can see here the updated overall survival curves that were presented in this last ESMO meeting in Paris. And as you can see here, this is a positive trial with a hazard ratio of 0.76 for favoring the combination arm with median overall survival of 12.9 months compared with 11.3 months. So with this, we have a new standard treatment option for the patients with biliary tract cancer, especially in the United States, in which FDA recently approved this combination for this population. So this is a new standard, at least in the United States, where they have approved this treatment option. The TOPAZ trial also demonstrated a superiority in the rest of the efficacy endpoint, progression-free survival with a hazard ratio of 0.75 and also a superior response rate compared with the arm with placebo. And as it was expected, the combination of gemcitabine, cisplatin, and durvalumab presented a manageable safety profile with no toxicity issues. And what about the MSI patients? Again, we have this KNOT 158 trial with different tumor types, MSI tumors, and they include 22 patients with cholangiocarcinoma, MSI cholangiocarcinoma patients, and they reported 40% of response rate and 4.2 months of progression-free survival. So this pembrolizumab option for this subgroup of patients with cholangiocarcinoma is approved by FDA and also by EMA, and is an option for these patients. Let's move now to the target therapies in cholangiocarcinoma or in biliary tract cancer in general, and it's probably, as you well know, in the last decade, we have a lot of new treatment options and new target therapies in this subset of patients. We will review now in the next slides. First of all, as I said at the beginning, we have different tumor types that constitute the biliary tract cancer, and these different tumors presented this different molecular profile with different targeted alterations, and in these different tumors, we have to say that intrahepatic cholangiocarcinoma is the one with higher incidence of targetable alterations. In fact, here you can see the screening program of the 5202 trial. In this single-arm phase 2 trial, they test the efficacy of pemigatinib, an FGFR2 inhibitor, in patients with FGFR2 fusions. So we have to screen a lot of patients with an NGS analysis in order to find these FGFR2 fusion cholangiocarcinoma patients. For this, we have data from more than 1,000 patients with a cholangiocarcinoma, and we found that 42% of patients tested presented at least one targetable alteration. I think we can say that this is one of the tumors with higher incidence of targetable alterations among all the tumors. And when we want to analyze which are the most common alterations, we have that IDH1 mutations is present around 15-20% of intrahepatic cholangiocarcinoma. FGFR2 fusions are present around 15% of patients with cholangiocarcinoma. HER2 amplification is also present in around 10% of patients. BRAF V600T is also around 5% of patients. And finally, we have these MSI tumors in around 1% of patients. Let's start with IDH1 as a target in intrahepatic cholangiocarcinoma. The CLARITY trial, it was a randomized international phase 3 trial that included patients with cholangiocarcinoma and IDH1 mutations. Patients were randomized to be treated with ivosidenib, an IDH1 inhibitor, or placebo, and the crossover was allowed. So for this reason, the primary endpoint of the trial was progression-free survival. As you can see in this slide, this is a positive trial with a hazard ratio of 0.37. So this is a very, I think, nice and promising hazard ratio, not easy to achieve in this kind of clinical trials. And also interestingly, when you see the progression-free survival like 6 months or at 12 months, this is 30% in the ivosidenib arm and 0% in the placebo arm, and is 22% at 1 year in the ivosidenib arm and 0% in the placebo arm. And I think this is interesting. And also the median overall survival was superior in those patients treated with ivosidenib compared with placebo. However, the differences between both arms were not statistically significant. Why? It was expected because 70% of the patients treated in the placebo arm did crossover to ivosidenib after progression. When you apply this RPSFT method to adjust the results for the crossover, you see that the hazard ratio becomes 0.49. So with these results, FDA approved ivosidenib for the treatment of cholangiocarcinoma patients with IDH1 mutations. And moving now to FGFR as a target, we have different drugs, FGFR inhibitors, that tested its efficacy in patients with cholangiocarcinoma and FGFR2 fusions. As you can see here, all of them test its activity in single-arm phase 2 trial and reported promising activity. However, pemigatinib is the only approved by FDA and EMA, and infigratinib is the only approved by FDA. The 5202 trial is a single-arm phase 2 trial, include patients with cholangiocarcinoma in a refractory setting, and presented 3 different cohorts. One cohort with FGFR2 fusion patients, one cohort with other FGFR alteration, and one cohort with no FGFR alterations. And the primary endpoint of this trial that treat patients with pemigatinib and FGFR inhibitor was the overall response rate. As you can see here, only the arm with FGFR2 fusion patients presented promising activity with 35% of response rate, because the rest of the arms presented no activity with pemigatinib. So it's only restricted to this population with the FGFR2 fusions. In this population, we have this progression-free survival of nearly 7 months, and you have to take into consideration that this is a really refractory population. And interestingly, in this ESMO meeting, it was presented the preliminary results of a new FGFR inhibitor. This is a selected and irreversible FGFR2 inhibitor, the Relay 4008 drug. And they presented this data in refractory FGFR2 fusion cholangiocarcinoma with a response rate of 63%. And when they look at the activity of this drug in the patients treated with the recommended dose, they achieve an overall response rate of 88%. So really promising results, and we will see with the mature data of this trial if this can be confirmed. Also, today we have 3 ongoing clinical trials, phase 3, that are pemigatinib, infigratinib, and futibatinib, are tested in first-line setting compared with cisplatin and gemcitabine in those patients with cholangiocarcinoma and FGFR2 fusions. And then the patients can do the crossover, and for this reason, the primary objective is progression-free survival. We have to say that it's very difficult to recruit patients in this kind of clinical trials because we have to test for the fusions before to start the clinical trial, and sometimes it takes a lot of time. So moving now to another interesting target, that is HER2 overexpression in biliary tract cancer. This is interesting because it's frequent in intrahepatic cholangiocarcinoma, but more frequent in gallbladder and in ampullary, that are tumors with only few treatment options. Different drugs tested and demonstrated activity in this subgroup of patients with biliary tract cancer. For example, zanidatamab is a bispecific antibody that targets simultaneously 2 sites on HER2 and demonstrated in a phase 1 clinical trial that include this biliary tract cancer with HER2 overexpression, a response rate of 41%. A phase 2 clinical trial was completed with around 100 patients with biliary tract cancer with this HER2 overexpression in the refractory setting. And we will see the results, and we'll see if we can confirm the response rate of 41%. Also, it was published the results of the combination of pertuzumab and trastuzumab in the same population with a response rate of 23%. And in the last ASCO meeting, the Korean cohort of patients treated with trastuzumab deruxtecan and with a biliary tract cancer with HER2 overexpression reported this response rate of 36%. And now we change to BRAF V600T mutation that is present around 5, 7, 8% of patients with biliary tract cancer. And the ROAR trial, that it was a basket trial that include different cohorts, and one of the cohorts include patients with biliary tract cancer and BRAF V600T mutations. And in these patients treated with dabrafenib and trametinib, they reported this forest plot with a response rate of 50%. And this is really a good treatment option for those patients that presented this mutation. I have a really nice cases, the patients with really a tumor that progressed to all standard treatment, and when you treat with this combination, they can respond really nicely. And also we have the fusions. The cholangiocarcinoma, sometimes in this 1-2% of patients, they can have NTRK fusions. And of course, if we have a cholangiocarcinoma with an NTRK fusion, we can treat with larotrectinib or entrectinib with really good activity. And the RET inhibitor, we have this Libretto trial published recently that also include 1 patient with a cholangiocarcinoma and RET fusion, and they treat these patients with RET inhibitors with really good activity again. So to sum up, biliary tract cancer is a really heterogeneous group of patients. Cisplatin and gemcitabine remains the first-line standard treatment option, at least outside of the United States, in which we do not have durvalumab approved. Intrahepatic cholangiocarcinoma presented a high percentage of targetable alteration. Maybe I have to highlight IDH1 mutations, FGFR2 fusions, HER2 amplifications, and BRAF V600T mutations. The TOPAZ trial demonstrated that cisplatin, gemcitabine, and durvalumab presented a superior overall survival than patients treated with gemcitabine and cisplatin, so establishing a new standard treatment option for these patients, for example, in the United States, in which FDA approved these combinations. Of course, NGS analysis is a must in this disease because if we want to apply all these new treatment options with this promising activity in this subset of patients, we need to find these patients. And for this, it's important, especially in intrahepatic cholangiocarcinoma, to do this NGS analysis in order to find these alterations. Also, to take into consideration that to do this NGS analysis, it takes time. So sometimes it's important to do it as soon as possible in the evolution of the tumor of the patient in order to have the results and to prepare the treatment options. And with this, thank you for your attention.
Thank you, Teresa, and we'll keep questions also to the end of the session. And now it is time to surgery. We welcome Dr. Mohammed Fathi Abdelghaffar, Professor of Hepatobiliary Surgery and Liver Transplant in Shams University, one of our eminent liver transplant team. And his talk will be what is new and how to improve the results of Whipple operation. Dr. Mohammed.
Thank you, Dr. Khalid. Today we are speaking about a very important topic, which is the pancreatic carcinoma. I will talk from the surgical point of view, how to improve the results after surgery. We know that pancreatic adenocarcinoma is a very aggressive tumor. We have a 5-year survival, about 8.5% in all stages. The American Cancer Society estimates approximately 60,000 new cases. And if we look to this figure, from these 60,000 patients in 2021, 48 will die. So it's a disappointing disease. And even more concerning, it's increasing. And we estimate by year 2030, pancreatic cancer will become the second leading cause of cancer-related death in the United States. So we are speaking about a very serious problem. The only curative hope for this patient is Whipple operation, the pancreaticoduodenectomy. The main goal of surgery is the complete oncological resection with a free surgical margin to achieve what we call a DR0 resection. And this is one of the most important prognostic factors. The anatomical location of the pancreatic head in the Ansen process, surrounded by the superior mesenteric vein and artery, and celiac trunk, make the surgical dissection very delicate and make cancer removed, leaving remnant tumor cells in the resection margin, or by cutting very close, exposing early recurrence. And one of the famous surgeons in pancreatic surgeons, Professor Buchler, always says the pancreatic surgeon is a vascular surgery. It's a vascular surgery because we are dealing with the major vessels. If you are not very well oriented and very well trained on vascular surgery, you will be afraid from this part, and this will be on the extent of resection, and will decrease the instance of R0 resection. Although surgery with the adjuvant chemotherapy remain the only potential cure, cancer still recurrence of about 80% of patients. And this, I think, one of the very rare tumors that you tell the patient you will be exposed to a very large surgery and you will receive a chemotherapy and you expected to have maybe 80% recurrence. I don't think we have such a tumor. So this is raise our thinking that there's something wrong. And maybe we have to improve the chemotherapy, the target therapy, but we have some surgical issue in this topic. Recurrence after curative intent surgery, some say it is 75%. Incomplete lymph node dissection, perineural dissection are considered factor associated with local recurrence. Furthermore, local recurrence occur more frequently in patients with a positive resection margin. And one of a very nice studies done in Germany, and they describe what is a true resection margin. We always look for the pancreatic resection margin, which is not only the resection margin. They mark the vascular resection margin, the superior mesenteric vein and superior mesenteric artery, and they found that what is called true R0 is achieved only on 20% of cases. And 80% they are R1, they are not a true R0. And this 20% figure may make a clue for this high incidence of local recurrence after resection. And some studies post-mortem, they found that the local recurrence is 100%. So, as a surgeon, how we can improve our results in such cases? I will focus on the surgical techniques to improve the recurrence, not all the results of the Whipple operation, concentrating mainly on 3 topics, which is total mesopancreatic excision, venous resection, and lastly, what we call it the triangle operation. The total mesopancreatic excision, Gork and co-workers described for the first time the mesopancreas as a firm and well-vascularized structure extending from the posterior surface of the pancreas behind the superior mesenteric vessels. And in block resection of this area, this is what we call the mesopancreas. And the idea comes from the colon surgery, where they did the total mesorectal excision, and they improved the results with this. So, as a pancreatic surgeons, we think about this and we try to imitate this. And this is, the figure shows what we mean by the mesopancreas. It is the tissue extending from the head of the ulcer process behind the superior mesenteric vessels. A few years ago, when we are doing the Whipple operation, we just cut beside the vessels. But now we have to retract the vein, we have to retract the artery, and remove all the tissue extending below the artery and vein to achieve a true clear margin. Total mesopancreatic excision was suggested to achieve a complete excision of the mesopancreas during Whipple operation in order to achieve what we call it the R0, the true R0. The second point is the venous resection. In-block vascular resection during Whipple operation to achieve tumor clearance improved the survival in case of portomesenteric vein involvement. And this technique was published maybe 30 years ago, but it takes maybe 20 years until it became popular and widespread, and most surgeons now accept to do venous resection. The pancreatic cancer of the head and ulcer process are in contact with the superior mesenteric vessels, and they may invade them. If the surgeons is not aware of, the surgeons is not familiar with the vascular surgery, he will be afraid to injure these vessels. So, and this will end with incomplete resection. And we don't have actually a true signs for invasion. And so sometimes we do resection just and make a frozen section to be sure that this area is infiltrated or not, because after chemotherapy, the fibrosis occur, and this you cannot differentiate between fibrous tissue and the malignant invasion. The NCC guidelines support the approach of venous resection if tumor infiltrate is suspected without any additional remark. And we have some signs intraoperative suspecting there is a venous invasion. This, like if we have a venous irregularity, if we have a vein short segment occlusion of the vein, this is very suggestive that we have a direct invasion, and in these cases we have to make a resection and anastomosis, and we have different technique to deal with it. We can do just lateral resection. If there's a small part of the vein can be resected, we can do a patch, we can do a venous grafts, which may be synthetic, maybe natural grafts. And this is a lot of studies done for the patient with a venous resection, and did not show any increase in the morbidity and the mortality for this patient. And this is the different techniques we can do during operation to deal with the venous involvement during the operation. Either we can do tangential resection, end-to-end anastomosis, segmental resection, put a graft. The last thing is the triangle operation. This was described by Professor Büchler and the Heidelberg group in 2018. And he described that we have in the operation a triangle. And this triangle is made by the superior mesenteric artery, the celiac trunk, and the portal vein. And we have to clear this triangle. And he thinks that the main cause of local recurrence is this area. And from their study, they found that the local recurrence decreased from 40% to 20%. Okay. And this is one of our cases here. You can see this is a superior mesenteric vein. This is the cut surface of the pancreas. This is the splenic vein. This is the hepatic artery, the common hepatic artery. And this is the splenic artery. And we'll see now the celiac trunk. This is the celiac trunk. And from the other side, what's hanging is the superior, this is the portal vein by the retractor. Okay. And this is the celiac trunk, and this is the superior mesenteric artery. This is the aorta from here. And this is the IVC, this is the left renal vein. This is the anatomy, and this is the area should be cleared in every case. This is another case, and you can see again, this is the IVC, this is the left renal vein, and this is the celiac trunk. And here we will see the superior mesenteric artery. This is the superior mesenteric artery. This is the celiac trunk. And this is the aorta. And this is the superior mesenteric artery. And we'll see now the triangle, what we call it, the triangle operation. This is celiac, superior mesenteric artery, and the portal vein above. We have to clear this area. And in this patient, we are hanging the portal vein, and all the vessels are cleared in this area. Next slide, please. And this is a case, another case with resection, tangential resection of part of the vein. You can see here the suture line. We just resect the lateral wall of the portal vein. And again, we are clearing the triangle between the superior mesenteric artery. This is hanging here. And this is the portal. And we'll see here the celiac trunk. And this is a video for venous resection, where here we cut the portal vein and we do end-to-end anastomosis. And you can see here, this is after declamping of the vein. I started this technique from 2018. Till now, it's 51 cases. The preliminary study is like this. Local recurrence occur in 2 cases, peritoneal nodules in 3 cases, liver metastasis in 3 cases, liver and lung metastasis in 5 cases. In conclusion, positive resection margin in pancreatic cancer is associated with poor outcome and is independent prognostic factor in survival. And from this point, we have to focus on what is the true resection margin. It's not only the pancreatic resection margin. The total mesopancreatic excision is a real surgical concept that could be started at any pancreaticoidectomy because it is a safe and feasible and allow increase the number of harvesting lymph nodes and increase the rate of negative resection margin. Venous resection during surgery for pancreatic cancer can be regarded as the standard procedure in experienced hand and should be performed in routine setting to achieve complete removal of the tumor. The triangle operation carries the hope of decreasing local recurrence, which may be reflected on the patient survival. Thank you.
Thank you. Thank you, Dr. Muhammad. I was holding my breath while the video is on. I will start my first question. Is there any idea or any data about to increase this local control by intraoperative radiation therapy? Intraoperative radiation therapy.
Actually, even the radiotherapy after or before Whipple operation makes the operation very difficult. And some surgeons consider it as a contraindication for surgery. I did a lot of 2 or 3 cases post-radiotherapy. It's very difficult operation. But I'm not sure if there is in Egypt here the machine for the intraoperative radiotherapy. It will be good if I remove and you did the radiotherapy. It will be very beneficial, but I'm not sure that this is available in Egypt because we have a same problem in the hierarchal-cholangiocarcinoma if we consider transplantation for hierarchal-cholangiocarcinoma. One of the main contraindications is you have to do an intraoperative radiotherapy, and we don't have the intraoperative radiotherapy.
Thank you.
Okay. I have a question for Professor Muhammad about the morbidity that will come with going with venous resection and triangle surgery. So will morbidity increase with this kind of more safer?
Yeah. In the study I did, I passed into 2 phases. The first phase, it may be the first 6 or 7 cases. And we have one mortality and we have some morbidity. What I noticed that if a pancreatic leak occur, the incidence of aneurysm is more, and the complication of aneurysm in the nearby vessels is more. So we learned that when we're doing this section, we don't make a very close to the adventitia of the artery. If you preserve the adventitia of the artery, the incidence of aneurysm, if leak occur, will decrease. And so in the next few cases later, we don't do just on the intima or the adventitia of the artery, we leave a very small area of tissue to protect these arteries. So they may be the only hazards of this technique. You are afraid if pancreatic leak occur, then you are afraid of aneurysm of these arteries.
Perfect. So if anybody from the audience would have, Dr. Ali?
Assalamu alaikum, Dr. Muhammad. Really, I'm impressed by your talk. And I have a question for you about the level of lymph node dissection in pancreatic adenocarcinoma. Do you proceed to what is known as D2 dissection, even to the celiac lymph nodes?
Yes, this is now routine. I have to remove the old celiac lymph node, superior mesenteric artery lymph node, and this is part of the triangle operation. Previously, we don't dissect the celiac lymph node, but now it's part of the operation to remove. one of the adverse effects of dissecting the celiac lymph node is the diarrhea post-operative. And they have, all the patients will have a diarrhea post-operative, but it usually improves within 2 to 3 months. So dissection of the lymph node is mandatory.
Yes, another question, please, about the maneuvers you should take to improve and refine the results of malabsorption and metabolic abnormality post-weapon.
Sorry?
Is there any surgical maneuvers to improve malabsorption and the metabolic abnormality after weapon?
I asked this question for Professor Pushra. He was here in Egypt, and asked about the diarrhea. Did he notice an increase of diarrhea after surgery? He asked me how many patients have diarrhea after. I said to him, most patients. He said to me, then you are a good surgeon. If the patient do not develop diarrhea after Whipple operation, this means incomplete resection. It's unavoidable. But most patients will improve with time. It may take 1 month, 2 months, and with Imodium and some medications, this is improved. But it is unavoidable.
Oh, thank you.
Okay, so thank you, Dr. Mohammed.
Shukran.
Well, I have a question for Professor Teresa. So actually about your first talk in metastatic pancreatic carcinoma. So if I consider my patient to be somehow intolerable to FOLFIRINOX, he cannot tolerate, or he's just like he cannot really hold the toxicities that you can get with FOLFIRINOX, even with modification of the dosage, and you know he's BRCA mutated. So what kind of chemotherapy would you give him?
So if the patient presented a BRCA mutation,
Yes, you have a BRCA mutation.
yeah, so this combination of cisplatin and gemcitabine that Eleanor really is
Is the only
always
option.
defending, and I think it's a really good combination. So I have a very good experience. It's well tolerated, so and is active in this population. So I think it's a good option.
So what percentage in your practice? So we know FOLFIRINOX is superior. We know that Gem and Abraxane is actually also a good option. So do you still, other than my exceptional situation, do you still use gemcitabine platinum? Is that right?
No, I only use gem platinum in BRCA mutated patients.
That's it. Yeah.
Except for this population, I never use it. So I use FOLFIRINOX in patients young and fit. But in Spain, we use a lot gem Abraxane. So we are I don't know, we use a lot even in patients with good performance status. And also we use gem NAP in patients, old patients and frail patients. And we have a really good experience, and we publish it in Journal of Clinical Oncology because it's very well tolerated, even in this population.
So what's your turnaround time for BRCA testing? So you tested early on, right? I would think so.
Yeah, I asked for BRCA in the first visit of the patient. So when the first time that I visit the patient and say, okay, go for BRCA today.
Before saying hi. So
today you have to go with a nurse to take the blood, and then 4 weeks more or less. So if the patient is in FOLFIRINOX, fine, no problem. If the patient is with GemNAP, and then I realize that it's difficult to say. If you are in the second cycle and you are waiting the CT scan, sometimes you wait the results of the CT scan because some patients with BRCA respond to GemNAP. So in these patients, we continue with GemNAP, no? But if I am in the first cycle, I try to change to GemCis.
Yeah, because this is the question have an extension actually. So if I'm talking about Onivyde, so pegylated liposomal irinotecan, it's actually based on you taking gemcitabine platinum in the early. So if you taking FOLFIRINOX, so you will not have a chance to give. So this is counterintuitive. So you're actually losing a line if you use the benefit. So
so also you have to think in the sequential treatment, no? And this is the sequential treatment. We do not have today any data of drugs that are working after FOLFIRINOX, unfortunately. So do we not have randomized data? And we have for Nalirian 5FU after gem-based chemotherapy. No? So one can think, okay, I start with GemNAP, and then when patient progress, I have Nalirian 5FU. And if you want in third line, you can try with oxaliplatin. No? So you have a sequential treatment there. But of course, we try to use FOLFIRINOX with young patients. I don't know. In Spain, we use a lot of GemNAP, even in young and fit patients. But Yeah, there's some patients that respond very well to FOLFIRINOX, so we cannot say. Also, I use GEMNAP after FOLFIRINOX, but we do not have randomized data, so it's something that we are.
Yes. So that's what we have.
Any other question? Dr. Ali.
So I wonder, where do you allocate the molecular profiling in the management of cholangiocarcinoma in early and in metastatic session? Do you ask for it at time of as early as installment of treatment?
Yeah, so in theory, you have to do it when the patient is advanced, no? Because you use this information in the metastatic setting, because we do not have any evidence of to use target therapy in the localized disease. But I do it once the patient is, if I have a patient that come to me after surgery, for example, I do it in that moment. Why? In order to be prepared for the relapse, no? Because I know that 80% of my patients will relapse, and we have some projects that allow us to do it, the NGS in the surgical specimen, and then once the patient relapses, you have the information, no? Also, for example, because we have these clinical trials in first-line setting with FGFR inhibitors, or also there's some clinical trials with IDH1 inhibitors. So if you don't have this information, it's very difficult to do it once the patient is metastatic. So I try to do it as soon as possible.
Okay, and do you follow the suggestions of molecular profiling, even if it is devoid of the clinical evidence? Sometimes the suggestions is out of evidence and sometimes weird.
So when I have a target that is a potential target, no, I try to see if I have a treatment option. For example, if I have a B600T mutation, I try to give the combination of TRAM and there. Sometimes it's not approved, of course, because it's only in single-arm phase 2 trials. I try to find a clinical trial, and if not, I try to use as a passive use. But I try, yes, if I have a patient that I think it could be a good target, I try to include the patient, especially in clinical trials. If not, yes, I use for not all the targetable alterations, but some of them like BRAF, MSI, the fusions, IDH1, FGFR2 fusions. Yes, these ones. Yes, because the benefit is there. No, yeah,
Okay,
I try.
thank you. That's very cool. Thank you.
Thank you, and we have to catch our schedule. Thank you, Teresa, and thank you all audience. And now we close the session. Thank you.